private practice healthcare attorney based in Hartford, Connecticut. Her areas of practice include regulatory and corporate compliance, bylaws and professional rights, health information technology, liability and risk management, contract issues, and professional ethics for all levels of providers. It is wonderful to welcome Jennifer back to our annual educational program. All right, thank you.
Well, he was just taking it away from you.
That's all that was.
Yeah. I forgot, I couldn't find these. They're right there. Just gonna grab my bottle of water. Good morning, everyone. It is fantastic to be in person and see folks. I am going to make an effort to stay in this area. It's got a camera going today for the folks who didn't feel comfortable coming or who wanted to get a recording of this. So how many of you in the room, and I'm going to assume some who are going to watch the tape, have not seen me give a presentation before? Have not seen me? Okay, so there's at least one, so we're going to do it. Yeah. I usually start the same way, but if it was everybody, you've already seen it. But it's on tape, so we'll do it anyway. So here we go. When I was a brand new lawyer, my firm would send me out to do talks all the time. And as a brand new lawyer, I thought, wow, I must be so good at this. They send me out all the time. Nope. Turns out they send out the kid at the law firm that doesn't have enough to do because it's cheaper for them than sending someone who does have something to do. And I found this out because when I had finished a program, and this was quite some time ago, so you got a written evaluation sheet, you know, at the end where you could write down stuff like the room's too hot, the coffee's not good, that kind of thing. But I got a comment on one of these written evaluation sheets that said, if I only had an hour to live, I'd want to spend that hour at your seminar because nowhere else would an hour seem like an eternity. So it's not high praise. So I examined that, and it turned out at the time, again a long time ago, I had about 400 overhead gels. Some of you in the room don't know what that is. So an overhead projector is essentially a mirror that puts something up on a screen before we had PowerPoint and electronic things. And I had about 400 pieces of law and regulation and statute, because I'm a lawyer and that's what I need to know. And it's probably very boring for non-lawyers to hear it that way. It's probably boring for lawyers to hear it that way. And so what I realized from that was what you need is some distillation, some synthesis of what you need to know. So we are not going to go through the law books today of exactly what all the laws we're going to talk about in the Law and Review for 2021. We're going to talk about why it impacts your practice. So that's the plan. And the other part is we're going to do this for like 3 or 4 hours, so there's that. But we're going to break it up with lunch in the middle. It's great to see everybody again. I have, it said in the bio, it's my old bio, that I'm in Hartford, but I've actually given up my Hartford office. I'm in Guilford now at my house. So I like to get out. This is one of the few times I get out. During the pandemic, I got out so infrequently my car battery died, so I'm not good at getting out of the office/house. I actually have soft pants in my bag in case this doesn't work. So we're going to try our best today. As always, if you have a question at any time, please ask it. It doesn't have to be what I'm talking about, and we'll try to get you answers. We've woven in Q&A time, but you don't have to wait for the end for that to happen. Did you guys get the slides in advance at all? Okay, so it'll be a mystery. We're going to talk about a bunch of things today. So I left the clicker all the way over there. It's this thing. Okay. This morning, we're going to talk about COVID-19. I just realized if I can't see that, I can't do it. COVID-19 response, legal compliance, the extraordinary changes in law and how they affect medical practice because of the pandemic. It would be silly not to talk about it because A, we're still in the middle of it. B, it's really interesting because the pandemic has tested not just our resilience as a healthcare industry, but how the different parts of government and healthcare interact in essentially a slow-moving emergency, which is what we're in, a never-ending slow emergency. And then we're going to go through the 2021 major Connecticut law changes that were passed by the Connecticut legislature that affect healthcare and medical practice, which is our usual thing. Then we're going to take the break for your business meeting and lunch, and then we're going to have more ITIS stuff in the afternoon. So they have announced significant changes to Hipaa and then they haven't finalized it, but I want to show you what they are to be ready, because once they finalize it, it'll look a lot like we're going to talk about today, and you only have 6 months, which isn't a lot of time to get up to date. So we're going to go through those. And then we're going to go through 21st century cures, interoperability, information blocking again. I know we did this last year, and I'm sure you've done it in the interim, but I'm going to say it again. If we were not in the middle of a pandemic, we would be talking about information blocking all the time from a healthcare perspective. It's really important, and if it's been something you haven't prioritized, and who could blame you, because you have a lot of priorities right now, it's something you need to start moving up the list. We're going to go through that again, and unlike the Zoom meeting, this will be an easier place to ask questions if you have questions. So let's get into the first part of this. So for federal regulatory changes in the COVID-19 response, for a non-wartime situation, it's been a while since we've had an actual wartime situation, the powers that both federal and state government are using are extraordinary. It's not something we've seen, certainly in my legal career, where how things are supposed to work are completely discombobulated. You can understand that and why it happened, since we're all living through the pandemic, and certainly during the winter and spring of 2020 when, all bets were off. Things were crazy, right? We didn't know where that was going to stop. When you're getting 8,000 deaths a week in the country, something's going to give. And there's a tension developed both between how the law is supposed to work and normally works when we're not in an emergency, and state law, federal law and state law. So there's a tension, and you see it in the news. Probably see it in your job as well, depending upon where you are in the industry. The tension between state and federal powers. We're going to unpack that a little bit today. Significant changes to Medicare and Medicaid coverage during COVID-19. For one thing, even though the government goes out of their way to make it sound like they never have enough money to expand anything for Medicare and Medicaid, for COVID, and I support this, although I'm saying it sort of tongue-in-cheek, apparently there's an endless supply of money from the federal government. So they are going to pay for everything so that there isn't a barrier to access. That's an interesting example, right? So we in industry are saying, there are things that you should be paying for or promoting, and there's money involved, and when there's not money, it doesn't get done. COVID-19 is the example of why that's absolutely true, and everyone seems to recognize it for COVID-19. So things where Medicaid and Medicaid would never have paid for stuff before, changing that, at least temporarily. And remember, a lot of this, if not all of this, is temporary. So we're getting used to an environment that hopefully goes away, because that means the virus has subsided. Significant relaxation of provider reimbursement rules, not just related to COVID-19. So the most obvious example we're going to talk about a little bit in more depth is telehealth. They went from, I don't really love telehealth, Medicare hates telehealth, Medicare doesn't like audio-only telehealth because they think that's just the phone call, and now they like it because we didn't have any choices in the meantime, which is a huge policy shift. Again, temporary. You talk about some of the ins and outs of how that works. Funding and assistance to the states and for distribution to the states for various programs for the federal government. This was alluded to during the sponsors discussion. Apparently, there's, again, an endless supply of money for whatever it is we're doing during the emergency. So money is flowing through at least 5 different major federal programs, either to hospitals or healthcare, for provider relief, for employee relief, for unemployment relief. There's a lot of cash moving around. And there's a lot of cash moving around without the normal audit and capture functions that government likes to have, because they're trying to get it out quickly. We'll say mistakes get made when that happens, and that continues to unravel. It's incredibly complex, the levels of funding, with FEMA being the payer of last resort, and then a bunch of what we would normally think of as grant programs, but because it has to be done quickly, they're just skipping all that stuff. So that adds a level of complexity. Significant data collection by various federal agencies. So I'm talking about federal now, I'm going to talk about state, but significant. The amount of personal health data that is being collected by the federal government related to COVID or even semi-related to COVID has probably doubled during the emergency. And again, query whether that will be temporary while we're dealing with a public health emergency, or the government will say, well, I like all this data in addition to the Medicare, Medicaid data I usually have. What can I do with it? Interesting for me, who tracks health data as part of my job. So we talked about the public health emergency, and it isn't evident, because how would you know, unlike state law that has a totally different way that we declare a public health emergency, whether we're in a public health emergency, the federal law runs in 90-day stints. It's just how the law works. It's the way the law is written. So every 90 days, and right before it expires, the federal government has to renew the public health emergency to keep all of these temporary health laws and payment rules in place. And so right now we're in a period that started October 15th, so it will be a while. But when you hear, well, when is the telehealth thing going to change? Or when is the Medicare thing going to change? Or things that may have affected your practice? Or when is the provider relief program going to end or subside? It is tied to these dates, these essentially artificial dates where the federal government decides it's going to use emergency powers, as if we were at war or with the virus, in order to not have to do all of the regulatory things they would normally have to do to make laws. Still in federal law, there's something called the PrEP Act you've probably heard about. And the PrEP Act was there long before COVID-19, and it's used to encourage the deployment of what the federal government calls countermeasures. Countermeasures are normally, we see them in the cases of vaccines for everything, not just COVID. And what it does is it allows the federal government to trump state laws without really consulting with the states, which is not normal. Again, we use these only during declared emergencies. And the countermeasures can be anything that Health and Human Services and their departments, ASPR being the big department, decide is a good idea in order to combat whatever the health, in this case, health emergencies, COVID-19 is. So we've got, at this point, the vaccines, obviously. We've got the regular treatments like infusion treatments. We are now going to have a bunch of antiviral tablets, essentially. Why is that important? It's important because, remember we talked about on the first slide, the tension between state and federal government. Who's in charge and who tells who what to do? That's tricky. You, in the state of Connecticut, some of you have licenses. Certainly your practitioners have licenses, so you're bound to do what the Department of Public Health of the state of Connecticut tells you to do. But then you got the federal government coming in and saying, I don't care, I want you to do this with either infusion medications or antiviral medications. And how do they get from the federal government to a pharmacy to you? So with the vaccines, that was primarily in Connecticut run through institutions, pharmacy and hospital, mostly because the nature of at least one, if not two of the vaccines needed the sub-zero amount. So they couldn't go to doctor's offices with needing to have something at 100 degrees minus Fahrenheit. You wouldn't be able to do that with a refrigerator. You have to have special equipment. So that sort of took care of itself. They didn't do it that way in every state. Did a good job in Connecticut, actually. We got after the initial, didn't do a great job, but did a good job getting vaccine out. So that's good. We obviously have a high vaccinated state. The next thing was the infusion medications, some of which worked, some of which didn't, but everyone would try anything right in the middle of a crisis because infusion takes a certain amount of space, time, certain level of staff. It's not like you could do that anywhere either. The new thing we're going to see is these antiviral tablets you've seen perhaps on the news. They're going to start getting approved this week, so you could do that anywhere. You could do that anywhere. So the question is whether the Department of Public Health has to tell the federal government how they want to distribute that. So we don't know yet how they're going to do that, but that could be anybody. So query whether they go through pharmacy or they go directly to practices or what they're going to do. So that's still up in the air. There's an amazing amount of lack of consensus about how these things would work between the federal and state government, between the various state governments. Some of you have practices on the border or even have a practice in another state that you work with. You might get entirely different answers to how do we distribute the antiviral pills. Might be done differently in New York than in Connecticut. That adds another layer of confusion for patients and certainly for you as well when you're planning. And it creates more tension between the state and federal government. Multiple COVID-19 related emergency use authorization. So emergency use authorization is what the FDA uses when it doesn't wish to go through an entire authorization process for a therapeutic or some other type of countermeasure. So we've seen that on almost everything, and then we see the manufacturers catching up to try to get a full authorization that doesn't have the bells and whistles of the emergency use authorization. So that's going to continue for all of these countermeasures we've talked about, because if you went through a normal FDA process, you're talking 3-4 years. Obviously, we can't wait 3 or 4 years for treatments in the middle of a crisis. There's an uptick in reimbursement for hospitalized patients. Interestingly, if you look at, DPH actually has state of Connecticut has a pretty good website, tracks COVID numbers. Tracks new cases, it tracks trends, it tracks percentage, it tracks deaths, it tracks location by county. And you'll notice in that it actually says how many patients each day for the day before are hospitalized and how many are COVID positive, and of those, how many are vaxxed versus not vaxxed. And it's interesting data, mostly just to watch, but additionally, if a person is hospitalized in any state right now because of the federal funding, and they test positive for COVID and they have to be tested, then the hospital gets an uptick in payment whether or not that patient is in as COVID as a primary diagnosis. And the reason is it takes more PPE, it takes more space, it takes more isolation, it costs the hospital more in order to treat a patient, all the patients, to avoid everybody getting COVID. Makes sense. Patients' right to visitors and attendance has been adjusted as the pandemic waxes and wanes at I'll call it the beginning or the first half of 2020. I think most of you are aware most hospitals and health systems and probably a lot of your offices either made rules that there couldn't be visitors or there could only be entirely necessary visitors as we got a little more control of the virus or a little more understanding and had regular precautions and masking. That's relaxed. One wonders, though, if there is an uptick for winter, as there would normally be for seasonal flu, with COVID, if we aren't going to go back to that a little bit, that creates a lot of tension. I think it's fair to say that in the last 10 years, in prior times, prior to COVID, we were starting to get an understanding that not just folks who need a caregiver, that's a different kettle of fish, but folks do better if they have the people with them that they want with them for care, if they're more engaged with their care and they've got folks helping them. When we stop that, when we break that chain, that creates a barrier to care. So we've got problems. Obviously, infection prevention is incredibly important, and the same coin, other side, it's incredibly important that people are engaged in their care, and if we are putting up barriers to that, that's a problem. So that's going to continue to be a tension. Change in Medicare policy for telehealth. I'm going to remind everybody that is temporary. We don't know exactly how temporary, but at least as long as the public health emergency, but probably not a lot longer than that. There's a policy shift in what's called crisis of care standards. I think it's very interesting because as you heard in my very long bio, I do patient rights and ethics issues with healthcare providers. And what crisis of care standards means, it refers to when you have either a shortage of therapeutics or space or staff, right? You can only take care of so many people. It's essentially a lifeboat situation. You got 10 people, but you can only take care of 8. Which 8 do you take care of? Prior to the pandemic, it was universally thought, and you can find it in the literature, you can find it in almost everything. It was universally thought that we would save the folks that were most likely to survive. Now, there's some logic in that, right? The folks most likely to survive have a better chance of survival to begin with. If we treat them, they might make it. If we treat people that aren't likely to survive, and when we let 2 other people go, that was a bad bet. That was the universal understanding in medicine and medical education. COVID has changed this. It's the most rapid cycle change of an ethics policy in healthcare in a really long time. And what has changed is the federal government in the Office for Civil Rights, which sits in Health and Human Services, made very clear to all of the states that they had to make clear to all of the hospitals and providers that that way of thinking does not comply with the Americans with Disabilities Act or the Rehab Act that is like the Americans with Disabilities Act. It's essentially discriminating against folks who have a disability or an illness, which is not supposed to be allowed, if in a lifeboat situation, you take out the sick people. So this blows everybody's mind because for the last 40 years of organized medicine, we were doing it the other way, and now you gotta flip it. Whether it's logical or not, and it'll take a while it's the one time where law actually is ahead of where regular things organically happen in medicine, it has now become clear that can't be the way you choose who you treat. You could do first come, first serve. You can always avoid care if something is futile, but futile means that person's almost certainly not gonna survive. Not they have a less chance than somebody else who just walked in. It sounds like a little thing, it's actually a huge thing. So it's one of the interesting things to me as a lawyer and a person who studies medical ethics. The pandemic I wouldn't say it has silver linings because that would be an overstatement because the pandemic sucks. The pandemic, though, is going to have a ripple effect for medicine and medical legal issues for a really long time. We just don't even have the time to study it right now because we're still in the middle of this very slow-moving emergency. Osha, who is a workplace oversight regulatory body, as you know, mandated at President Biden's request vaccination rules for 2 different groups. Here I'm talking about the employers with 100 or more employees, and CMS, not OSHA, mandated certain healthcare facilities do mandatory vaccination. You probably saw in the news that different federal courts have put those rules on hold. There's going to be a big legal debate in many courts. It'll probably take years, like it might outlast COVID, as to whether or not the federal government has that power. If they do have that power, does it have to be exercised by Congress? That is to say, can the president do that, or does it need Congress to do it? Can the states do that? So it's super interesting to me. For you, you're going to see this. We're in a state that clearly favors vaccination and mandatory vaccination in healthcare settings, whether or not the federal government wants it. But what is the effect if this is going to reach the Supreme Court? So it's right now just at the district court level, then there's an appellate court level, and then the Supreme Court. If it gets to the Supreme Court and the Supreme Court says you can't, the federal government can't do that, isn't the next logical question a bunch of lawsuits about whether the state can do that, right? That's how that works. So it's interesting because it won't just affect COVID and vaccination. That'll affect a lot of things. We've gone, again, for 30 years with rules about tuberculosis testing and treatment, about what your pre-physical issues are depending upon what unit you work in. There's a lot of this at stake that will change how the employment environment works for almost every level of folks who work in a healthcare setting, not just facilities. So I think it's safe to say court challenges still to come. I really think that all of the who can do what can the federal government tell you to do as a person? What can the federal government tell you to do as an employer? What can CMS tell you to do just because they give you money for Medicare and Medicaid? That is all going to get checked again. The law as we thought it all was prior to the pandemic does not seem to be the law that's going to be post-pandemic, which is interesting. It could only be interesting to me, but it is interesting. Because when you had a world where kids absolutely had to be vaccinated or they can't go to school, you had a world where an employer can tell you you've got to get vaccinated or get a TB test or whatever, whether you like it or not, and now that might not be the world we have. And that will have a lot of ripple effect. So this seems remedial, but it's not. I want to go through this a little bit because it is important, because when you read stuff in the paper, it's like half right most of the time about why this stuff is happening. There's so much happening. It's like a fire hose of information of legal health issues during COVID. So America has 3 branches of government. I know you know that part, but it's really important right now. So we've got an executive branch, so in the federal level, executive, legislative, and court system. So president, Congress. When we say the president, that's actually all the agencies as well. So CMS is in the executive branch. Then Congress, and then the courts. And the courts are, again, 3 levels of court. And at the state, we have a similar thing, obviously with the governor instead of the president, and then the General Assembly, and then we have a similar 3 level of courts. Each have a specific power, and part of the gig, you remember this from 10th grade history class, part of the gig is that they're supposed to put checks on each other. Like no one branch of government is supposed to get so far out of the power that it can't be corrected or have a course correction by the other 2. This is like an experiment in a box, COVID versus the law, and how this is going to happen. You have like a perfect storm of things. It's really important. It's deadly. It affects the economy. It affects interstate commerce. And it affects personal rights, religious rights, and your right to autonomy over your own medical decisions. That's a lot of things to be in one area. It's a slow-moving process because normally when something works its way through either the state or federal court system, it's years, 3, 4, 5 years before you can get from A to B, sometimes longer than that. We don't have that kind of time to figure this out, so it's going to be on an expedited path. There could be major shifts when we're done with all this, including, at the end, the vaccination rules, what can or can't be mandated by a state or employer, might be topsy-turvy to what we knew. So that's an interesting thing we're going to have to watch. Religious rights, and not just vaccine related, and this is going to come up in a minute when we talk about state laws in Connecticut and children's vaccines, not just vaccine related, but you may recall during, again, 2020, when there were, you can't have more than 10 people in a room, can't have more than 50 people, remember all that? Which hopefully we don't get back to that point. So that applied in some states, including New York, to everything including churches. Churches didn't like that because they consider that every time the government makes a church do something, it's a tension between federal powers and a religious right under the Constitution. So the Supreme Court actually said, in a case that wasn't fully argued, so you're sort of reading the tea leaves, that maybe the government can't do that. Maybe the government, even if everyone is going to get the plague, can't tell a church that they have to close. So that's a really interesting thing that's going to regurgitate onto healthcare about who can take a religious exemption for what and when. And then I would not be doing my job if I didn't say there's a lot of court issues right now on reproductive rights, and although that has less to do with COVID, it obviously has a lot to do with where is the edge of medical autonomy. We have spent since 1973 in a world where the physician-patient relationship has constitutional weight, and your ability as an individual to make decisions was fairly clear, and it seems evident now that it's not. And I would suggest to you that the mix we're in with COVID, where everything is sort of crazy from a legal perspective and accelerated, is causing that conversation to be accelerated as well. So you're thinking, well, 50 years is sort of a slow conversation. Yeah, but I don't think it would be so obvious that it was going to go this way if we didn't have all this other acceleration of these issues that are pretty serious issues. So the reproductive rights cases that are working their way through the courts now, one of which was argued in the Supreme Court this week, and so they will have a decision on that at the end of June. They always have the big cases that make everybody unhappy come out in the last week, and that the last week is the second to last week of June. So we will know, and it's going to have reverberations for what patient rights are right across the board. So that would be a huge ethicist issue. It's going to affect right to die. It's going to affect futility. It's going to affect consent for care. All of that's going to come back into play. COVID-19 and Hipaa. So since I like Hipaa a lot, we're going to talk about the intersection of COVID-19 and Hipaa. A lot of things happened mostly in 2020, sort of petered out after things got, I'll call it under control, although I don't know what line we use for under control, where the federal government in Health and Human Services, the good folks that control CMS, temporarily, I'm going to keep saying it, these are temporary changes. Like at some point, I don't even think it's going to be a smooth glide path. They're just going to give us a date, probably like a week in advance, and say all the rules are back to where they were in 2019. If we can remember what those were, that's going to be stunning. So temporarily changed a handful of HIPAA-related privacy issues in order to accommodate the new normal, hopefully the temporary new normal of the pandemic. So Hipaa and COVID-19, just by throwing notices up on their website. Normally, again, this acceleration thing becomes important. Normally, if I'm fighting the HVAC. Normally, so I talk softer now, when the Office for Civil Rights or CMS makes a new rule, it has to publish it in the Federal Register. They have to let at least 30 days go by for comment. They then have to wait 60 days till they're just doing this like, I put a notice up. So they put a notice up for like 17 different things, changing the law for all intents and purposes. To me, that's crazy talk. To you, it's like, just tell me what I have to do. So via notices on the website, federal government put a handful of HIPAA changes up relative to COVID-19. The first and most important is, and don't over-rely on this, the Office for Civil Rights, the group that enforces HIPAA, intends to use their enforcement power in a nicer way. If you're doing something because you're trying to respond to the pandemic, or your entire practice is out of joint because you're responding to the pandemic because things are weird now, they're going to try to be nicer to you if you have a HIPAA violation. So that's something nice. Also, they've relaxed some, not a lot, of HIPAA security measures. And I saw a lot of things go by in the trade papers. You probably get a bunch of these emails that say, oh, you don't have to do whatever for HIPAA anymore. None of that's probably true. So I'm going to go through exactly what you do and don't have to do anymore. They re-explained, most of the notices were re-explaining how HIPAA is supposed to work in the first place, and nobody was doing it right in the first place. But when it comes to the pandemic, you gotta be sure everyone understands the rules. And that Hipaa flexibility, this is me talking, is very narrow. Whatever the federal government did to relax Hipaa for the purposes of fighting the pandemic, it's not a lot. So I don't have to do that because of COVID, the Hipaa part. Probably you do have to do it and you misunderstood what they said. So I want to be absolutely sure you didn't take too much extra leeway there. So here's what they actually did. First thing they did, which is a real change and affects some of you, is they made a decision that a business associate, your business associate, the one you have the business associate agreement with who does stuff for you, could give information to a public health authority if a public health authority requested it without you telling them to do it. So that's odd. You're like, why would you need that? Well, the answer is at the beginning, when they could not, you remember, I remember distinctly, federal government couldn't get a handle on which state had how much COVID, where it was it nursing home, was it community setting, et cetera, and nobody had these data, except the hospitals have these data. But the hospitals don't work together, right? They're in Connecticut, you've got 27 different hospitals. In Massachusetts, you've got 50 different hospitals. Everyone's got a bunch of hospitals. They don't normally work together. But there are both the hospital association in each of the states, and for the state, the Office for Health Strategy, they get a lot of data, mostly claims data, but they could suss out a lot of the picture. So the federal government said, I don't have time for each hospital or each Department of Public Health to figure out how to collect these data. I need these data right now. So they made a HIPAA rule that said, if a public health authority, now that's an actual public health authority, that's either the Department of Public Health or a tribal Department of Public Health or somebody at HHS or one of their branches says, I need these, then whoever's holding your data as your business associate can give it to them and tell you about it later, which is actually extraordinary from my HIPAA perspective, because you're supposed to know where your data are being used all the time. That's part of your obligation. In this case, if your BA did that without telling you, they were both doing it legally and would be a surprise to you when they tell you later. So that's the one big change from my perspective they made, because that's not how that's supposed to work. But you can see how tripwires get tripped in an emergency, slow-moving emergency situation, because the government does not have it set up for this. Because here's the thing. It needs to be said even though you know in the back of your mind. You cannot set up a system, a public health system, a health industry, government, to be functioning in an emergency all the time. You can't. It's too expensive. It doesn't make sense. There's no reason you would do that. You want to have rule of law, steps, calm reflection. Right now, we don't have time for rule of law, steps, or calm reflection. So they're making up as they go along because they have to, and it means that corners get cut. The thing for you to ward against, don't cut corners you're not supposed to cut, because it looks like a free-for-all, right? It is not. Most rules are still in place. Very specific rules have been relaxed. Security requirements were made only slightly more flexible for two things. One is telehealth, and one is your scheduling systems, essentially. So outside of your EMR, you might have another module that you're doing, either referrals or patient outreach or your scheduler, which has to be HIPAA compliant, right? But it doesn't necessarily match with your EMR. They made those two things at the beginning of pandemic where you didn't have to, and I'm going to beg you don't take them up on this, it didn't have to be secure to normal security standards. The reason they did this was they wanted telehealth to be everywhere, right away. And if you were already doing telehealth, it was already secure, because that's the rule. The rule remains the same. Telehealth is supposed to be secure, technically secure. You can't just use Dropbox or pre-secure Zoom. You can't just use FaceTime without checking to see if it's secure. And they said, well, AMA and the American Hospital Association went to them and said, we can't do a lot of telehealth unless you make it easy. And so they waived the rule on security. This is not a great idea. There's a reason that telehealth has to be secure, so other people can't hack into the information or record the information, et cetera. So what they actually said was, temporarily, until you find your way to a secure solution, if you're doing telehealth, you're allowed to do it on a non-secure platform. I'm going to repeat, and Peter's probably twitching. It's a horrible idea to do telehealth on a non-secure platform. Horrible. But you are allowed without necessarily breaking the law, but you're supposed to be moving towards a secure platform. It is not a get-out-of-jail-free card for just using whatever you want to do telehealth. So if you're doing telehealth and you took them up on, I'll do this and I'm not sure it's secure, My recommendation is you go back and find a secure method. There's too many secure methods now available to you in order to continue to do it in a non-secure manner. Will they cite you for it? No. Should you be doing it? Not a great idea. Because what's going to happen is somebody's going to have a breach, and then someone's going to realize when there's audit or investigation it wasn't secure, and then you're going to have to explain why you sat around for a year and a half not finding a secure solution. April 2020, understood. December 2021, much harder to understand why you haven't moved to a secure platform. How to contact patients about therapies was clarified. This is one of those things where folks who don't understand HIPAA because it's so ridiculously complicated think they understand it, and they don't really. So folks were saying, well, I can't reach out to my patients and tell them how to get, at that point, any of the therapeutics, or when we got vaccinations, how to do it, because I'm not allowed to X, Y, Z. And everyone had it wrong. So they clarified. They didn't change anything. That of course you're able to reach out to your patients because that's treatment, even if you don't know if they're coming in to talk about it. So hopefully those barriers no longer exist. There's certainly a lot of confusion about who can tell who what about their vaccination status or about their COVID status. Some of that's employer related, which isn't healthcare related, oddly, and some of that is patient related. So you need to separate in your mind, am I talking about this about my employees and their healthcare situation, which is an HR function? Or am I talking about my patients, even if one of my employees happens to be one of my patients, which adds a layer of complication. So you need to be sure which thing you're talking about. They put in aggressive reminders twice about not allowing film crews or media on site at your facility or place where there may be patient care. And yet, I turn on the news, even yesterday, and I still see this. We talked about this in 2017, 18, 19, probably last year, although last year was different, and right now. Here's the rule. The rule has not been relaxed, and they went out of their way to twice put out a memo saying, have you lost your minds? There is no way to have a media crew, a media person, a photographer, a person filming, anybody like that at all, in your care setting with patients unless the patient has pre-consented on a Hipaa-compliant authorization. Got it? I don't want to see their feet sticking out of the bed. I don't want to see their mom talking about them. I cringe. It is not HIPAA compliant, and it's cool when the film crew comes, got it. It's not legal, and they can't, they're exasperated at HHS and OCR because they don't understand what you don't understand. You can't ask the patient later. You can't put a blue dot on their face. You can't modulate their voice. None of those things work. Pre-consent on a HIPAA compliant authorization is the only reason a media person or film crew can be where patients are doing what they do. That's it. There isn't anything else to it. You will turn on the news this week and you'll see it again. I don't understand it. It seems like a simple rule. So that's going to continue because it is very impactful when we hear from patients and families and caregivers, particularly caregivers right now, as you all know, probably better than anyone, are at the brink, right? Folks are retiring. Folks are tired, folks are stressed. The slow-moving emergency just seems to grind on. People are stressed. So if they say, you know what's going to be great, our media team, or this media team thinks we can get better exposure, we can get folks to come if we tell personalized stories, great. Be sure you have pre-consent in writing of any patients that might be involved in the personalized story. This is, if they catch you doing this, they are not going to like it. It's an easy thing for them to catch because it's on the news, which is recorded. Please don't do that. Rules for first responders and workforce exposure and patient status were clarified. So it was the rule before, it is the rule now, both under Connecticut law and parts of federal law, that if you have to inform a first responder or a caregiver about somebody's medical status in order for them to take prophylactic measures to protect themselves, you can. That has not changed. That did not change with COVID. But everyone got confused, and so what happened was the ambulance, at the beginning, when it didn't look like we were all gonna be involved, and we're all involved, but we didn't know, ambulance drivers were getting sick at a much higher rate, and before we went to universal masking and all that jazz, they wanted to know if the person in the ambulance had COVID. So then it was, I can't tell them. Yeah, you can tell them, it turns out, because you've always been able to tell them. So there are rules for that. Those rules didn't change. OCR issued guidance on COVID vaccinations and the workplace. So this was bold even before the federal court blocked that this week. So here's the thing. Because if you do accept Medicare or Medicaid dollars, you're bound to do whatever CMS tells you. Usually they do long rulemaking, but now they're just making stuff up as they go. One of the things they told you was if you're in certain healthcare settings, you need to have mandatory vaccination or a very narrow exemption practice regarding either medical or religious exemptions, and there's a whole rigmarole to this. The federal courts have put a hold on that. State of Connecticut has not put a hold on their mandates, which are similar but not exactly the same. And when, this is one of the most interesting questions I get because it's so far, in my mind it doesn't fit, but I've gotten it so often I can see why it fits for others, so I want you guys to be armed with this information. So the Office for Civil Rights that does Hipaa, and it's actually kind of an interesting piece if workforce meets patient stuff interests you, put out a very long white paper, FAQ, whatever you want to call it, explaining why a person doesn't have a Hipaa right to keep their employer from knowing COVID stuff. Wow. So they could have just run 2 sentences. It could have said your employer can find out or can't find out XYZ, but it goes on and on and on. And it's not exactly correct, which is concerning to me, because most of the things they wrote were correct. So the guidance that OCR issued on workplace issues that affect Hipaa rights does not focus on those of you who have healthcare setting and employees both at the same time, which is the thing they should have focused on, and they didn't. They go out of their way to say the thing you all already know, but no one else knows because it's too complicated. Hipaa information, PHI, is generated by only 3 types of entities: health insurers, healthcare providers who bill electronically, and healthcare clearinghouses, which are third-party billing switches, which we don't even have anymore because everyone's electronic. So the Hipaa right is relative to controls on you as a healthcare provider who bills electronically or a health insurer. Nobody else does Hipaa, right? As an employer, let's say you were Home Depot and not a healthcare entity. If you're Home Depot, you don't do Hipaa. Nothing about you is Hipaa, right? So the Home Depot, just using it because I was there the other day. You're not supposed to use names of things, but mostly drug companies. Home Depot can mandate its employers get vaccinated, can ask its employers COVID-y things, the stuff you can do that doesn't violate OSHA rules or EEOC or CHRO employee HR rules. It's got nothing to do with Hipaa. Hipaa never comes into play, which is what this really long piece says. Problem for you is you are a healthcare provider and an employer, and sometimes your employee gets healthcare from you, and now is that Hipaa, is that not Hipaa? And we've always had that struggle, right? And now we really have that struggle because those 2 things don't fit very well. And so that paper isn't quite right. The thing that you get out of it that you should keep in mind: 1, consult an HR professional, either a consultant or a labor and employment lawyer, for how you're going to do everything you do from now on about COVID, about vaccinations, about health information, because this got real very quickly with the pandemic. The second thing is what they will tell you, and as you all know, I am not a labor and employment attorney, so I'm just going to hit the surface on this because I don't want to mislead you. The Americans with Disabilities Act applies, and the Rehab Act, which is a lot like it, applies. So from a disability medical exemption perspective, that's got to get recognized, and what a person does or doesn't have to tell you about their condition for which they wish to have an accommodation, that has not changed. So Hipaa has nothing to do with that either. So Hipaa only imposes obligations on health insurers and healthcare providers who bill electronically. That's why it doesn't matter. So what they conclude in this paper that is of no use to you is employers don't have to worry about Hipaa because a person doesn't have a natural Hipaa right to protect their COVID information. But a patient has a natural right to protect their COVID information, right? And they might also be your employee. So that is a confusion for those of us who work in healthcare industry that has not been resolved. Is it occupational health? If it's occupational health, is that Hipaa? Do they have to sign something first? Does it matter where they work? All that stuff now is like on fire, and we're going to have to work through it, and probably we're going to have to find out after all these court cases come down where that line is, which we thought we knew where it was 2 years ago, and now nobody knows where that line is. Operational tip. If you are relying on COVID times flexibility, we'll call it, a temporary change by a payer, using telehealth on sketchy security platform, anything in all of the stuff they talked about public health authorities, if you're relying on some flexibility you think exists or does exist, please document that, because if they come for you at some point, and they're gonna go, why are you doing this? You're gonna wanna say, because of that memo, and you wanna be able to point to it. Even if you're wrong, your reasoning about why you aren't doing HIPAA the way you're supposed to do is gonna be better for you than, I don't know, seemed like a good idea. That's never a good answer. So if you're relying on that flexibility, particularly if you choose to rely on the flexibility regarding telehealth and you are using a platform that is not a secure technical method, which I beg you to don't do, please document why you think that's okay and what steps you're gonna take to get to a secure platform. Because you can't just, they're gonna say, why don't you have a secure one? And you're gonna say that thing, and they're gonna say, what thing? And you're gonna hope you had already pointed to it. So be sure that you are documenting any aberrations of how you do HIPAA if you think it's because you're allowed to do something different, and cross-check whether you're actually allowed to do something different, because most of it's still exactly the same as it always was. I'm gonna take a sip of water. Any questions about that? It's riveting, I know. So I'm actually excited about it, as you can tell, which makes one awesome. I really do think it, besides being the most extraordinary event of our lifetimes, or certainly mine, it is going to be the most extraordinary legal impact on healthcare that we're going to see in 100 more years, if we're lucky. Once is enough. Okay, this is that was federal. This is Connecticut law changes that happened in 2021. Now, interestingly, even though the General Assembly was virtual, that is to say no lobbyists or people or kids on buses could go to the Capitol, and these guys worked mostly at home on Zoom, they got a lot done. So when I was getting ready for today, I was like, God, they didn't do that much this year. It turns out they did a lot. So we're going to talk about what changed in Connecticut law in 2021. I'm going to start with the COVID stuff because it's obviously top of mind. There were a lot, like we lost count of how many executive and agency orders came out during COVID from the state of Connecticut. Executive orders where the governor uses his emergency powers to make rules that normally would have to be made as a law. You can't just make it, but he's just making stuff up. He has that power. And these are also temporary changes. So a lot of these things have already sunsetted, and a lot of them were, it is hard to remember. It was not that long ago, but at the beginning of the pandemic, it was really weird. Like they were doing all sorts of weird legal stuff. And then they sort of moderated, and hopefully it's steadied out. So there are primarily temporary or short-term changes to state law that the governor did or a commissioner of some agency. Might be public health, might be social services, might be mental health and addiction services. There's a bunch of agencies that had a lot of different rules during COVID. So we call those executive orders, EOs, or agency orders, AOs. And what those do is suspend or amend law while the emergency is happening, or from a date chosen by the government, which is what makes it confusing to follow, as if the governor was a king. And I don't mean that pejoratively. That's how the thing works. It's like, wow, the governor can just do stuff. Now, the control on that, we talked about 3 branches of government, is that the legislature, at some point, it's not exactly clear where, they're debating this still, at some point in time has to bless that or reject that. And in Connecticut, you're probably aware, the legislature is so overwhelmingly Democrats that they made a new thing, a totally made up a thing, where they have just like a group of the leadership signs off on stuff or rejects it. And so far they have essentially signed off on everything the governor's office has done. That is not how it's worked in other states. You could see in the news everyone did it a little differently because we've not been at war for a long time, and that's the only time these rules come up. They used a little bit of this power, a tiny bit of this power during H1N1. Remember H1N1 10 years ago? We're going to be ready for the next pandemic, that H1N1. They did like 2 things. They clarified if you would be taken to isolation if you got H1N1, and some other random thing about if they had a medicine, which they didn't, you might have to take it. Never happened, because we never got as fulminant with H1N1 as we got rapidly with COVID. So we haven't used these emergency powers on the state level in forever, which is problematic because they're rusty. So most of these are designed to take place only during public health emergency, and unlike the federal government, public health emergency runs in complicated features, but then blessed by the legislature. Right now, ours, we're going to declare the public health emergency essentially over in April 2022. We'll see, because so what if the public health emergency, what if COVID gets worse, right? We're going to go through an uptick. Obviously, we're in an uptick now versus the summer. And if we use and it turned out not to be true, but we're using the model of seasonal flu, and then taking the numbers and trying to see what it's normally like when we all go back indoors and stuff. So if that model continues, we're still going up in the bad way for a while. So will the governor come out and make a bunch more rules? Will he reenact some of the literally 100 rules they made that they're just making up laws as they go? Hard to tell. Or what if the public health emergency or a COVID lingers, right? Is there a number? And this is not meant to sound as cynical as it's about to. Is it number of deaths? Is it who's dying? Is it where they're dying? There's going to be a point. This is why it's fascinating, and I suppose sociologists will probably be picking this apart for years. What makes a public health emergency? How many people are in jeopardy versus how many people need to go on with their lives? And that's not settled yet, right? We don't know where that line is. It's different in every state. It's different depending upon who's running the federal government. So there's a lot of uncertainty on that. Government and both constitutions, state and federal constitutions, are not designed to operate in emergency. They are not designed to allow one branch of government to make all the decisions. So there's going to be a break point. There's going to be a point at which the safety issue will not be deemed as important as what we'll loosely call the liberty issue, or the fact that the government should function with due process in normal times. So that's interesting to watch because nobody knows where or when that is. And if it's different in every state, that gets really hard to manage after a while. But with the court cases we saw literally in the last week, all of which said the federal government may lack the power to take the actions they've taken, hard to tell. They aren't saying the states lack that power, and there's a whole reason that's different. The reason that's different, for those of you who are interested in this as much as I am, the states traditionally have the power to enforce healthcare laws since the beginning of the Republic. So if the state is the one that normally has that power traditionally and it hasn't been given to the federal government, then the state might be able to do the thing the federal government can't do. And then we're gonna have it 50 different ways, maybe. So that is still an unanswered question. So this deep into the pandemic, you would think lawyers, politicians, scholars would have gotten together and figured out at least what the choices are. Maybe not what you do, but what's allowed. They have not. They are so busy just getting day to day that they haven't figured out like what's the end game. There apparently is no end game. They're sort of chase the numbers right now. COVID-19 related, yeah.
Jen,
Mark.
some of the executive orders, I believe, were scope of practice related.
Yes.
Do you feel those will serve as an impetus for these organizations to really push to continue with the maybe enhanced or increased role they had with patient care?
Yeah, so this is a great question. So during some of these executive orders or agency orders, many of which have sunsetted, some of which are still in place, but most have sunsetted. But what Mark's referring to is there are things related to scope of practice for individually licensed or certified providers, practitioners, right? So these come in two major flavors. One is, can that individual do stuff that he or she wasn't able to do before, but they sort of know how or could be trained to do it? And so that comes up that came up aggressively in vaccination, right? We had to have a ton of workforce be able to vaccinate. Can't be just nurses, can't be just nurses and pharmacists. We had to bring a lot of people on board for that. So part of it is they used the Federal PrEP Act, and part of it is they said if you do these 12 hours of training, you too can be a vaccinator. So that is a scope of practice, horizontal, I'll say, expansion of scope of practice. Temporary and specific. So temporary to public health emergency and specific to that kind of vaccination. So to Mark's theory question, does that mean if we can, and we did, safely expand the pool of who can, for example, could be anything, give a vaccine, a COVID vaccine, why couldn't they be deployed to give pediatric vaccines or other things that they're not allowed to do? Why couldn't you do that? So we have a healthcare system that's very top-down, very licensure, certification related on who can do what, that in an emergency we decided risk factors different, we will change it. Does that change the way of thinking and make the government say, or organizations that support those particular disciplines say, I could do it yesterday, why can't I do it next week? Good question. Because healthcare would be a lot cheaper overall. Cheaper is always important, or the cost curve would be bent, whatever we're calling it now, if we could have more people do more things to be more interchangeable. True. The other thing is a vertical scope of practice change where Connecticut has been an outlier in allowing reciprocity of another state's license to allow someone to do something in Connecticut. We're like, I don't know why, we're just behind the times at this point, or at least behind the other states or surrounding states. So where many states would allow a physician or a nurse or others to, if they are licensed and in good standing in one state, to work in a different state after filling out a form. Connecticut's always like, I've never heard of that before, which everyone else does. So during COVID, as you all know, there's only so many nurses and pharmacists and doctors. We would have, frankly, would have taken anyone. Have you seen a medical school? Have you seen a doctor's show? We'd take anybody at this point. And so even though in normal times, and a little bit of our slightly odd New England look at how licensing works, or at least, but we're the last ones in New England even, who do this, why not have a nurse from Ohio be able to be a nurse in Connecticut? For all practical purposes, they study the same things, they pass the same tests, there are national tests you could use, et cetera. Why don't we do that? So I think the answer to Mark's theory question is on the first part that we discussed. I think they're gonna bounce right back to, no, you can't do that. I don't care you did it really well during COVID. We're gonna go back to our own turf war. So I think that's not gonna expand right away. I think the other thing is, I think Connecticut's finally going to have no excuse. What's the excuse for not doing the safe thing that all the other states do, which is if you're a nurse somewhere else, you can be a nurse here. If you're a doctor somewhere, you can be a doctor here. Those are called interstate compacts. Different states get together and say, basically the same rules, or I basically have the same test, or you could use a different test to be sure you're a nurse or a doctor, whatever it is. I think that's going to happen, and I think it's going to happen rapidly. I think it was probably 10 years away, it's probably 2 years away now. So that's good for pool, although as we found during COVID, there's not enough of anybody, it turns out. We didn't have enough anesthesiologists, and so then they put everybody in anesthesiology. Now you had too many of those. We don't have enough GPs, and so it's going to be like that. We always have these cycles in medical training. The third thing, I said there were two, but there's three, is telehealth. So here's the problem with telehealth. State of Connecticut in particular, much like the compact thing, doesn't like it when it's a doctor from somewhere else, and they particularly don't like it if Walmart in Texas wants to be your doctor, because they can't get to Walmart in Texas, right? They can't say you did something wrong, or medical examining board can't get to that doctor. That's their concern. So will telehealth of being, I don't care where it comes from, I don't care who it is, will that continue? I would suggest to you that it's probably going to be payer-based. If the payers continue to pay for it, mostly Medicare continues to pay for it, they'll let you keep doing it. Once Medicare says I'm not paying for that, everyone will be like, well, I don't want to do it anyway. So we'll see. There is a big difference between, yeah, I got trained in Massachusetts, I got my license, and I just moved to Connecticut. Do I really have to wait to get a license? And some pharmacy in Texas wants to be your doctor. Those are entirely different things to me anyway. So we'll see if that scope issue changes. You can do all that right now. Not even COVID related, just because COVID screwed everything up. So that is a nice thought question mark for today. Temporary limitations on liability have ended, but during COVID, when everyone's like, I don't know where it's coming from, I don't know what to do, I don't know whether to give you hydroxychloroquine, I don't know whether to give you bamlanivimab, I don't know. The state of Connecticut, like many other states, not all, said, we're not gonna have medical malpractice for decisions about COVID for a while in institutions who are desperately just guessing, because there's only guessing at how to treat people. Because you can see what will happen. Medical malpractice lawsuits take 6-7 years in good times. Now they're gonna take 10 to get to the end. And 6 years from now, we're all gonna think, how come they didn't, we're all gonna think, how come we didn't get antiviral pills right away? Because they didn't have them, but you're not gonna remember that part. So it would be unfair to hold medical practitioners to a standard of, I have no idea what to do 6 years later when it looks obvious what you should have known what to do. Nobody knew. So they made a rule where you can't sue in medical malpractice for anything to do with COVID for a brief time. That ended, so now you can get sued for anything to do with COVID, which is still interesting because you're still just guessing. Let's face it. When everything's on emergency use authorization, they're guessing at FDA, they're guessing at CDC, and you have to, because that's what we got. We don't have time to wait for the data to come back. So you still can get sued now if you make wrong choices that 6 years from now will seem worse than they were at the time. Unemployment, workers' comp flexibility, and a presumption about COVID being workers' comp related if you're in certain healthcare settings, which is it's a rebuttable presumption, meaning as the employer you can say it wasn't, because I know they were at a party where everybody had COVID or whatever it is, but it was a huge shift towards, first of all, pouring money into unemployment, as was mentioned by our sponsor, throws things off a little bit, but if folks have to eat and stuff, there's that. But the workers' comp thing is weird. So if you work in a healthcare facility and you got COVID, you must have got it there. Well, that doesn't seem right because, you know, people have COVID and they go everywhere. I go to the Big Y and I'm sure someone there has COVID, so you don't know. So that was weird. That might be temporary, might not be. That might be one of the things that slides into sort of a permanent workers' rights situation. Rehiring rules in industries that aren't healthcare related, so I want you to clarify when you see this. There was a law passed in Connecticut in certain industries, restaurant, janitorial, et cetera, the non-coded industries. If they got laid off and the reason was COVID, they've got to be first hire back situation. So that does not apply to healthcare, but I would suggest to you that consult with HR professionals to not use layoffs or COVID as a stalking horse to get rid of people you wanted to get rid of anyway, because that can come back to bite you as an HR issue later. Vaccine status disclosures by DPH. There is a law in the state of Connecticut that the Department of Public Health, that is the official receptacle for who knows who's been vaccinated, can't tell anyone who's been vaccinated except the patient or if the patient signs a consent. That was almost immediately countermanded and contradicted by an executive order. The executive order is still in place because the state of Connecticut is going to have to do stuff and report to the federal government about who's vaccinated, who's not, where they are, how we reach the rest of the people. They wouldn't be able to do that. And that was an interesting law that got kind of slipped through. One of the few things that wasn't controlled by the democratically controlled General Assembly and is not a good idea. From a data perspective, the public health should be able to use your data anytime they want. That's how it's always been. So that's a little bit odd. You're not restricted. You have your Hipaa restrictions, so you don't have a specific restriction for that. Telehealth, we talked about. After action review, so the state of Connecticut has made a law where it will have to study how well it did during COVID and the response it had as a public health authority, as a government, so to be ready for next time. As I mentioned, I'm going to say it again because it's worth saying. After H1N1, there was a 18-month committee, met all the time, wrote hundreds of pages of reports. You can read them. They're very useless. About what we'll do next time. And all of it was out of date, because 10 years is a really long time between pandemics. And H1N1 was nothing like this, right? Nothing. So they had stuff like, we will buy 100 ventilators, not enough, and put them on a shelf. They're there, by the way. So when this started, and if you remember, didn't have enough ventilators at first. And can't get them. It's like Philips can magic a ventilator. They have to go make it. And no one's at the factory because of COVID. So they were like, oh, I know. I have those H1N1 ventilators. They don't fit any of the current batteries. They don't fit any infection prevention controls. They're 10 years old. You can't stockpile 10 years of ventilators and expect to plug them in now. It doesn't make sense. And there were 100 things like that. All the stuff they planned for was out of date. All the data stuff they planned for was out of date. So they're going to do that again. They're going to have a report about what we're going to do next time, which will probably be 20, 30 years from now, if we're lucky. And it also will be out of date because governments are not made to run on emergency all the time. They're not. They're made to run in normal times. And we're not in normal times, so planning for running an emergency is antithetical to how it should work in the first place. I keep talking about telehealth, now I'm going to tell you how it works. So in Connecticut, so the federal rule might change. Like Medicare may stay at the end of the next 90-day public health emergency. All that telehealth stuff go back to 2019, which is honestly what we think Medicare will probably do when they figure out the price tag of telehealth is outrageously high and folks can go to the doctor. We don't have a lot of rural health here. We have a little bit in parts of counties, but we're considered urban care for CMS purposes. So even if they save it, they're going to save it for rural health. And we're not going to get the benefit of that, so they're going to relax that. But in Connecticut, the law, the actual law they passed was will sunset in June 2023 or earlier if the governor and the legislature decide, where our telehealth rules have changed. And our telehealth rules are primarily carriers have to pay for it if it's part of the negotiated provider agreement. The Social Services DSS Medicaid has to pay for it to the extent the federal government allows them to continue to do so. And most importantly, audio only is considered telehealth, which is how it's never, ever, 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 never been. Audio only is a phone call. And for years, doctors have appropriately said, why don't I get paid for that? It was the same 20 minutes I took to do whatever. And so during the pandemic, to be sure people had access to care, they allowed phone calls in certain circumstances on certain plans and the Medicaid program to be paid for as certain coded visits. Got it. Are they going to keep doing that? I'm going to guess no. I think I'm a fair guesser on that. I just do not see the federal government allowing that to continue, and sure as heck, the private carriers aren't going to want to pay for phone calls if they don't have to. They normally mirror the concept of what Medicare does, so that's probably what's going to drive that. So commercial insurers aren't excited about it, and we've also got now, you all have felt this, I'm sure, data coming back that although telehealth is nice when you don't have any other choice, it is not the same as an in-person visit. Patients are not as compliant. You can't touch them, you can't feel them, you can't give them certain tests. So the one place it is, the research is showing it does work is mental health and behavioral health. So either talk therapy or cognitive therapy that doesn't normally require in-person assessment regarding prescriptions or procedures, that might stick. We might get some of that sticking. The rest of it, they're going to be like, nope, if you don't live in the middle of Kansas, then you can get to a doctor's office, so you're going to have to go there. That's where they're going to end up going. They've also relaxed where the doctor has to be or the practitioner has to be and where the patient has to be, because those rules are made up in a time when people who made those rules do not know how their works, you can tell, because they talk about things that don't make sense technically. So I'm going to say, having said all of that, the payment rules are going to drive this. As soon as Medicare looks at that price tag, looks at the bill for telehealth, they're going to throw up and say, yeah, we're not doing that anymore.
Jen, we have a lot of behavioral health. We have 3 looking for 4. And most of the time, the patients come in, but we find that with college patients, they want to continue the therapy, and they're in Massachusetts,
Yep.
you know. Can we bill for telehealth?
So probably yes right now. The payment rules and the location rules have been relaxed substantially, but it is payer specific. So for the privates, you should check with them, with your rep to see just hey, I went to a seminar, I just want to triple check that I'm doing this right. For Medicaid, they have a whole person now, because they got so many questions, who can explain it, because they wrote it so confusingly. Like if you're going to do it in calm reflection, you wouldn't have written it this way, but they had to do it quickly, so they did it a funny way. So probably yes. There are other bells and whistles. Is that person a licensed person, and does it fit under the other executive order if they cross the state lines? If they're your continuing patient in non-COVID times, once they go somewhere else, except for continuity of care, in theory, you wouldn't have been treating them. And this is the people winter in Florida problem, right? So for adult medicine, you've got a patient, you see them all the time, and then they got a house in Florida, and then they're gone for 4 months a year, but they still want you to telehealth treat them. That's iffy, right? The first couple times for continuity of care, but Florida doesn't like it if you're treating their person while they're there, because it's supposed to be where you are. But right now, nobody cares about that. When this all ends, they're going to care a lot more. So from a licensure perspective, it's flexible. From a payer perspective, you actually should check with the payer to be sure that they think it falls within it. I can see, I won't say their names, but I can see the 3 big commercial payers at the end of this looking down at their telehealth bill and saying, ouch, and then coming back to you and going, oh, wait a minute, Johnny was in Minnesota or whatever. So I would check. Mental behavioral health. So in law, it's really evident now. It was kind of evident over the summer, or should have been for the last, 10 years. We are understaffed, under-platformed to serve mental and behavioral health patients. I don't know what else we have to hire afloat at this point to make clear. There are not enough resources for mental health, and this is being exacerbated by the pandemic. It's just getting worse. We have an access issue to physical access. We have ridiculous amount of stress. For most of us in our lifetimes, this is the most stress you're going to get from a community-related issue. So they passed a bunch of laws that seem sort of all over the place on this agency will look at that, and this agency will try to figure this out, or they'll have a committee to have a meeting to have a plan. So there isn't like, here's a bunch of money because we need to do this. We'll keep talking about it because we need more mental health stuff. So that is cynical, but that's what's happening. That's not going to be enough. Oh, there was one very specific thing. If you are giving mental or behavioral health, regardless of the medium, like I don't mean just telehealth, I mean any, and you have persons who are deaf or hard of hearing or deaf-blind, they have a new Bill of Rights for them. And here's the thing, because you are a public accommodation for medical and because of various federal laws, you are supposed to be getting either an interpreter or effective auxiliary aid communication for persons who are deaf, hard of hearing, or deaf-blind. You're supposed to be doing that already. And folks are mediocre at it for the most part because it's expensive. Because you will lose money on a lot of these patients. That's just how it works. And now, because folks who are getting mental behavioral health, it seems more extreme that folks are not good at getting them an interpreter or auxiliary aids. They got their own law. And during the midst of everything going on in the pandemic, the law passed. So we need to be careful about that. So the take-home message is know what resources are out there. There are 3 different major in-person interpreter services that you can get an open engagement contract with. You can do this on telehealth, but it's difficult. And there are specific rules from the Office of Civil Rights about how you have to comply with that. So you just want to know that's coming because these folks are very organized, which is good. I mean, no one's going to advocate for you but you, and they're advocating for themselves. And so that is a little bit of a change, not technically, but in reality, that is going to change. So you're going to see more need to have access to interpreters for deaf, hard of hearing, and deaf-blind patients if you are providing mental health services. We are in the middle of a mental health crisis. No one declared it, but I'm going to say it out loud. We're in the middle of a mental health crisis. We have lacked a sufficient mental health platform in Connecticut for years, and we continue to ignore that. And now we're coming to where the pandemic's making everything worse. Some of the increased need is just resource related for the pandemic, right? We moved folks into places we had to care for COVID or for different infection prevention issues. And then we've had different environmental issues. We have different socialization issues. We've got kids who weren't going to school for a long time. There's a lot of stuff that's going on that makes things more stressful. And some of it is just hyper-focus. You've got delayed care. Even for me to get into my own GP, I call the same time I usually call to make an appointment, and it was still 4 months later than it would normally be because you've got a bottleneck of access and need. That's much more true in mental health because we already don't have enough practitioners, and a lot of these are smaller folks. I mean, smaller practices, solos, and they don't have the resources to do telehealth or to do it a lot, and they don't want to have a lot more on their plate. So we've got a huge problem without a lot of answer. And so that is going to be, I would say, this year a focus for the legislature because now the hospitals not every hospital has that service. They got an emergency department, got people in them that need a residential or community setting, and there just aren't enough beds, there aren't enough providers. So this is a catastrophe on top of a pandemic waiting to happen. Data, cyber, privacy, and security. So Connecticut, so you got HIPAA, as you know, and if you have a breach, you do the report to the federal government. If it's 500 more people, you do it within 60 days. If it's less than 500, you can do it by the end of February in the following year in which the breach occurred. There's a long form to fill out. You know that part. State of Connecticut requires you to also give a notice to the Office of the Attorney General when you have a HIPAA breach. And that has been true for a while. Nobody was doing it. They strengthened that law so that it applies to every company, not just healthcare, that has personal information about a person and has a breach or a loss of the data. But the good thing is you don't have to go through their whole form like Home Depot would have to when they lose somebody's credit card information. You only have to send them a copy of the breach notice that went to the patient. It's not great. There's 4 people in this unit. They are overwhelmed. So as I understand it right now, they're looking at things from 2017, so it'll be a while. Yeah. Good news, and I'm sure Peter knows this, but if you don't, this is good. I'm never the bearer of good news, and now I'm going to be. So the state of Connecticut passed a law that said if you have a formal cybersecurity plan, okay, and HIPAA counts for that, so you've got your formal HIPAA security plan and it's up to date, you will get some credit if there's ever a lawsuit or claim against you. Not a lot, but some, and that's good. So you wouldn't get punitive damages or excess damages because you're like, I was trying. So even if somebody hacks you because they can, even if you have a good plan, that's a good thing. You already have it, so you're just getting the benefit of having HIPAA security. It's another good reason to be sure your HIPAA security is up to date. But this is meant to have medium-sized and smaller businesses that aren't working in banking or healthcare where we already have been doing security for 10 years to get their act together so that we don't have breaches of personal information. But you get a benefit from that. And on the horizon for 2022 and beyond, Connecticut is eventually, could be this year, could be next year, it's going to be soon, going to pass a law similar to the California Consumer Privacy Act, which is a bummer because you do HIPAA. HIPAA is a national framework. We drill it into you. You do it pretty well. Connecticut does great, actually, on HIPAA by way of outcomes. We have fewer breaches, we have fewer problems, we have fewer corrective actions. We do well as a state. And now we're likely going to have to do more, and it isn't aligned with HIPAA exactly. And that's going to be a pain in the neck. So maybe next year we'll be talking about that if they pass this law. The tricky thing is, so California passed a law, Colorado passed a law, Virginia passed a law. None of them are in place yet. But everyone's like, well, these laws are great. It's like, I have no idea how these laws are because they haven't worked yet. So that's unfortunate. So you will have to do more stuff about patient consents and information and who you can share it with, particularly if it's online, et cetera. So that's just more to come on that. And I mentioned this earlier with the federal government, but it's true of the state government too. During certainly the early parts of COVID, they realized at the state of Connecticut, they've got antiquated technological systems. They have antiquated ability to collect data or sort it, and they have not enough data analysts. So they're going to put resources into that, which they should have been doing, so they're catching up. And that's going to mean more data collected from you. That's going to be through a lot of different sources, and that's going to be at every level of healthcare, which is interesting. And a lot of more to come because the agencies have to put together their notices on what they want you to send them and when. They haven't figured it out yet. Scope and licensure. The biggie this year was physician assistants. Got a law passed modernizing what physician assistants can do to make it more like, but not identical to, what an APRN can do by way of scope of license. So they literally took all the laws for everywhere that APRN was added to next to physician and tried to add physician assistant to every one. About 80% they got, and some of them don't make sense because there is a distinction from a clinical training perspective between an APRN and a PA. There is, and so they didn't get everything. The other thing about that is, so for all intents and purposes, where you are deploying an APRN now in a collaborative setting, so a PA still can't be fully independent, they still need to have the collaborative agreement, where an APRN could be in certain circumstances independent, PA can't. But a PA can do almost everything an APRN can do, so you could deploy them in that. But I'm going to remind everybody an oddity of this. Many payers, and even federal payers, did not do that across the board. They did not replace where an APRN is the appropriate practitioner to sign off on something or pre-approve something, mostly for Medicare, Medicaid, and mostly for home care. PAs didn't get added to all those. So if you're going to deploy a PA, and you refer patients out, and you normally have an APRN sign something, stop and think, am I doing that because there's a payer issue? They might be allowed to do it as a licensure issue, but they might not be able to do it as a payer issue. So you want to be absolutely sure about that. And then the only other super interesting scope of practice change they made was they made continuing medical education on PTSD mandatory for most licensure categories. It was already mandatory for physician and APRN, and now they added it for almost everybody else who has the normal CMA. And you know what, it used to be, you got 24 hours every year or 50 hours every other year, depending upon who you are. And now they just started adding things. They've got 11 things now, and they've added PTSD to that. So that's a pain if you're buying more modules, but it's probably just another module. Big deal. Recreational cannabis and medical marijuana. So they sound the same, they're slightly different. So the law talks a lot about medical marijuana, and there was medical marijuana law prior to this year, and now there's recreational cannabis. And so it is absolutely true, as a matter of social convention, there are folks that believe calling stuff marijuana has specific historical negative connotation. So I mean no disrespect to that. It is still called medical marijuana in law, so I'm going to call it medical marijuana when it's in law, despite the fact that that may have historical negative connotation. And then I'm going to call recreational cannabis because that's what it's called in law. So there's a massive change to Connecticut's law on marijuana and cannabis. You had a medical marijuana law before, you had to have certain conditions, and your doctor APRN or P had to sign off that you had that condition, and then you had to get it from a certain dispensary, pharmacy, et cetera, and then with certain things, and you can't use it at certain places. Got it. That's still all true for medical marijuana, and medical marijuana is still a different potency, a different strain, a different dispensary. Medical marijuana is over here and hasn't changed a lot, although it changed a little. But they've now made just regular old cannabis legal, non-criminalized in Connecticut, and will be legal with certain assigned dispensaries, which are not going to be crossing over. So the good medical marijuana that has certain purities and human consumption standards is in one place, and the recreational cannabis will be in a different place. That updates just state law. For your purposes, I want to be very clear. The federal government still believes that marijuana is illegal. Medical marijuana has not been recognized, even medical marijuana has not been recognized by the federal government if it is not an FDA-approved substance, of which they have several synthetics with THC. But just marijuana as you think of it, not something the federal government has agreed to. They have stepped down enforcement, but the going rate is, particularly in a facility, you are not to order it, you are not to prescribe it, they don't care if it's medical, they don't care if it's recreational, you cannot have patients have it. So there's a huge disparity between federal and state law. And the other thing is, more important for your purposes, this second thing. The medical marijuana is different. It's differently made. It's differently sourced. It's different strengths. It is not good or ethical or appropriate, and perhaps if they're doing it, if anyone's doing this in your practice, send them to training to say, well, I was taking medical marijuana, but it's okay because now I'm just using, just smoke it up at home. Those are not the same thing. So to the extent it's important to a care plan, that is to say the practitioner wants this person to be on medical marijuana or agrees with that, want to be clear, if that's what's going to happen, figure out how to write that in the record in a way that doesn't say, it's okay because Johnny just smokes his brother's pot now. That's not the same. And it sounds the same, and you can easily see it, right? Maybe it's something the patient wanted, and they have glaucoma, and it's mild, and they were getting medical marijuana, but it costs a lot, and now it's free because their brother's just giving them pot. I get it. That can go in the record as recommended to patient they continue medical marijuana. Patient has decided they're going to use recreational cannabis. That's fine, but it ain't the same as I agreed with the patient recreational cannabis is a good idea. That is something I don't want to be seeing. Because I agreed recreational cannabis is a good idea, isn't medical. And it can, and let's think about chart review or something, it doesn't sound great on the other side. So just sounds like a small distinction and it doesn't touch everybody, but just want to clarify. It's okay to do, it's not okay to think of it as medical care, because they're actually two entirely different things. Do we want to break because it's 11, or do you say 11:30? I can't remember.
11:30.
I just keep talking, Chad, so, okay. I got more. I get more for the morning. These are still Connecticut laws 2021. They did a lot, which is funny because when I thought about it, I didn't think they did that much. Workplace and workforce. Super important, seems like an oddball thing, but here we go. Connecticut is the 7th state to adopt the Crown Act, which is creating a respectful and open world for natural hair. So it's essentially a natural hair non-discrimination law. Long overdue. Let's just be clear about what this is. You cannot tell employees who have natural hair, you don't like their hair that way. You don't like their hair that isn't, it could be a color issue, it can be a braiding issue, it can be different attachments, it can be anything. And I will be just openly, straight up clear with you about what this is. There is a history everywhere in America, and certainly in Connecticut, where persons of color who have hair that is different than those of us from white European descent are discriminated against because their hair looks different and it looks to some people to be unruly or unkempt or unbusinesslike. That is unacceptable. We do not get to decide that their hair, their natural hair needs to look like our hair. That's not cool. So that is now the law. In case you needed any more information on how to do this is an HR issue. You can consult HR consultants and lawyers about how it works. It's pretty basic though. I think it's what I just said. Now that does not have anything to do with a bona fide infection prevention issue or a mask issue or anything you need to do that has a legitimate bona fide medical thing. That's different. Does anybody have any questions on what I'm saying? Because I can say it again. I can say it more bluntly if you like. I actually remember this in my career. A bunch of folks I worked with in my first legal job very many times were told their hair didn't look professional enough, and it was just their hair. I'm not even kidding you. So that stuck with me, but then, like everything else, it just blends into the background. So it can't blend into the background. This is either an actual bias or an implicit bias that everybody at work needs to know, not just the folks that do HR stuff, obviously the folks that do hiring, review, et cetera, but everybody in your work environment. Next time you do whatever your work training is, tack this on so everybody knows. I don't even care if you think it doesn't apply to anyone in your workplace yet. Everybody needs to know this because it is going to now rapidly be, well, for one thing, for compliance purposes, it's going to rapidly be a test case. So be careful, you don't want to be the test case. Plus, it's just wrong. So we can do better than that. Various updates to employee rights and hiring fairness, including when you must disclose the wage range when you are hiring. Again, this is clearly an HR function, but be sure you know that. And they have changed allowable defenses about gender wage discrimination claims, meaning more narrow. So again, these are clearly HR, labor, and employment issues, but real. We've talked about this every year. We're tracking it. The minimum wage goes up $1 every year in Connecticut until 2024, when it's going to be tagged to the Employment Cost Index, a federal number. So be sure that, I'm sure you are up to date with that. And then a new one, time off to vote. You have to have 2 hours, you have to allow 2 hours for time off to vote, unpaid, and the person has to ask at least 48 hours in advance. It's not really that helpful, but you're not going to dock them PTO, is essentially what they're saying if someone's taking off legitimate time to vote in a legitimate election. Again, workplace and workforce. So effective over the next several years, it starts in 2024 and it ends in 2028, depending upon the number of employers. So the bigger you are, the sooner this comes to you. Your employer quarterly report relative to the unemployment labor department system, so filings for that. This is a theme we're about to see. This is the first time today we're going to see it. You're going to have to include a large amount of demographic information about your workforce. So right now you probably filed these if you have any unemployment, you have the unemployment insurance filing quarterly. Right now you only have to list some wage range issue and social security number, employee names. In the future, and this is important, we're going to go through this. You're going to have every employee's gender identity, age, race, ethnicity, veteran status, disability status, highest education completed, home address, address of primary work site, occupational code, hours worked, days worked, salary and hours, hourly wage, employment start date in the current job title, and if applicable, the end of employment. So I bring this up not because it's that hard. ADP or whoever you use is going to help you, whoever you use for your unemployment quarterly filings. I tell you this and I emphasize it because it's going to come up everywhere. That red thing I had a few slides back, data collection going up, that's not just healthcare. That's going to be everywhere. And they're going to start, the state of Connecticut has decided it was way behind and now it's going to try to jump out in front in collecting data where it might be able to see trends. Trends in discrimination, trends in race, equity, and inclusion, trends in different parts of the state that they think need grants or additional support. And it's very common with folks who get excited when they first see how data works. If they just had all the data, they could figure it out. So that's where their head is. All the data is everything, like everything about a person, half of which we tell you half the time not to ask them about, and now you're going to ask them and put it on a form. So this is going to get tricky. You're going to need HR consultants or ADP or whoever does it for you to help you with this because it's not just going to be unemployment filing. They're going to start doing it in other areas, I guarantee it. They just haven't gotten their forms together yet. Passed this year in the legislature regarding infants, children, and adolescent health. So this started pre-COVID, and now it's going to be a cluster thing, cluster fuss. Routine vaccinations for school and daycare, we've had that a really long time, right? So there's the pediatric list of vaccinations. Kids have to have them. If they don't have them, they might have a medical exemption, they might have a religious exemption, but for the most part, if you don't have them, you don't get to go to school and the whole thing takes over, right? Got it. We've had that for decades. They have taken away the religious exemption with a grandfather clause that if you were already bona fide taking it, you can continue to take it till you get out of school and you age out. But for everybody else, state of Connecticut no longer recognizes, as of September 2022, a religious exemption for childhood vaccines where they are mandatory for school or daycare. That sounded like a winner from a legal perspective prior to COVID. Everything you looked at, you could have 100 lawyers, 99 were going to say, yep, you can do that because there's 7,000 cases, and one lawyer would say, I'm not sure. Now that we are seeing the COVID mandate stuff trickle down, and it isn't as government supportive as you would have, the 99 lawyers would have guessed, this is going to get challenged much harder than it was going to get challenged pre-COVID. So right now that will be the law in September 2022, that for folks who didn't already have a religious exemption for childhood vaccines, there isn't one available. So the state's updating their forms. You'll see the new forms. In California, when they took away the religious exemption, what happened was a ton of docs then gave out medical exemptions to folks because the parents wanted the exemption and they'll get it. This is a very small part of everybody, and many of you are not in pediatric practice. Ones who are, you know that this is a pain. When you've got parents that are dead set on not being vaccinated, they will often use any route they can to get there. It's going to be very specifically ugly after we get the COVID rulings on how much religious freedom you do or don't have and what the government can tell you to do or can't. Yes?
Practice still have the right to discharge a patient?
This is a great question. So traditionally what's been happening, certainly in Connecticut, and I will say blue states for the most part, pediatric practices often will try to work with a family that is, I'll call it anti-vax, and if they get to a point where the family won't get on the plan, the practice will help them find another practitioner because they're no longer welcome at the practice. That's common, that is legal. I can't say for sure after these lawsuits happen what the answer to that will be. You can see, as in a lawyer's brain, if this goes way to the right, if the courts determine there is a very strong constitutional religious right to do X, Y, and Z, it could easily trickle back to you can't tell someone they can't come there if they won't get vaccinated. We'll see that play out. It's a very real possibility. It's 3-4 years away, but it's a real possibility because it's essentially using public accommodation and what competing with what someone's religious rights are can affect a private arena like a practice. So that is something that we're going to have to watch because we're going from locked tight, 99% sure to I'm about 40% sure right now how that's going to come out.
Our position has always been if you have children that are unvaccinated, they can cause a child who is not old enough to be vaccinated yet to become ill, and that's really been our position.
Yeah.
You know, the babies who aren't fully vaccinated and you have an unvaccinated child come in and spread them measles.
Yep.
And so we look at it as it's a detriment to the health of other patients in the office.
Yes, so the thing that Joanne said is absolutely true. It's well reasoned. It follows what we know about infection prevention. And yet, you can replace COVID with childhood vaccine and all of that. And COVID's obviously much more acutely dangerous, I'll say, than we don't have a lot of measles. When we have it, it's bad. But we have a really high vaccination rate in Connecticut, and yet we can still do better. When every time you start allowing exemptions, the vaccination rate plummets. Most of that is just convenience, but some of that is folks really don't. There's a small vocal group of folks that really don't want their kids vaccinated. And so the question is, do they end up, right now they just end up at certain doctors that are okay with that, and that's okay. I mean, there's a balance in nature that works on this in business. But I have to say, I really think it feels evident watching the cases go by that the COVID thing's not going to come out on the side of, I'll say, science. It's going to come out on the side of rights that sometimes are anti-science, and in this case, it's what they teach you in law school is called the counter-majoritarian difficulty. And the counter-majoritarian difficulty is, the thing that Joanne said is like, well, I'm going to accommodate one person and 1,000 people could get sick. I don't want to do that. The counter-majoritarian difficulty says if you have constitutional rights, then that one person is as important as 1,000 people at the same time, literally. So I'm 40% hopeful, which means 60% sure this is going to go the other way. Like, we will have a different framework for what's required and what has to be allowed to be exempted. And I'm sure AMA and American Academy of Pediatrics will have a big voice in that. But right now, does it sound like it doesn't, because of COVID, we talked about this at the beginning, this is like, it becomes evident legally more and more. Everything's upside down right now. I mean, the voices of reason or the institutions or things we have that we already had a lot of trouble with because they're very stodgy and they move slowly and all that, no one's even listening to them. It's sort of like a free-for-all. And we're coming up on a midterm election. Congressional seats are up in the House. Folks are grandstanding. It's going to get weird before it gets normal. Even if the virus goes away, we're going to be dealing with this kind of fallout on who can do what, when, where, and who can tell you not to for years. And interesting way to make. Minors may seek out, this is a new law, or it's actually an amendment to an existing law. Minors can seek out more outpatient mental health care than they could before without parental consent. This used to be called the 6th session rule. So a minor could seek essentially cognitive therapy, talk therapy, no prescribing. I mean, it might be prescribed, but not about prescribing without parental consent for up to 6 sessions. And then the prescriber would have to write up a note about why he or she or they thought that the person should continue without parental consent. They've scrapped the 6, essentially. So an adolescent can seek mental health, outpatient mental health care if prescribing isn't involved. So it's usually a psychologist, social worker, marriage and family therapist, those folks could see an adolescent without parental consent. You still got to get paid, so that's usually where the rubber hits the road on this. Like, as soon as you give someone your Anthem number, it turns out Anthem sends a thing back, EOB. So there's still that problem, but it's possible, and certainly there are clinics and different networks and platforms that have access for kids that need mental or behavioral health services, but their parents aren't on board yet. So that is to the good. That is to say, it promotes access to care for adolescent health care. That was a big fight, though. And I suggest to you that parents exercising more rights over children and consent will go to the right as we get this COVID stuff sorted out legally. And then something called the Connecticut Parentage Act. This is one step towards recognizing what's called intended parents. So instead of having to go through adoption in certain limited circumstances, folks can agree that this other person who isn't traditionally related to the person can be the parent on the birth certificate worksheet without having to go through the adoption step. It's way more complicated than we have time for, but the general idea is we're taking one step towards allowing non-traditional families reproductive justice issues for when it wouldn't make sense to just go through the whole thing for adoption when everybody knows what we're going to do by the end. But it doesn't work in all circumstances. It has specific effects for fertility and surrogacy and how that will work in Connecticut. So if you are involved at all in fertility services, reproductive health, or surrogacy, you're going to want to go to a program on this and only this, because it's very specific, very complicated. It brings up other issues. The other issues it brings up is, now I got somebody with, are these the right parents? What about the parent that I thought was the parent? There's all that kind of stuff. So it doesn't affect everybody, but you need to know it's out there because it's just one step in a move towards reproductive justice that we might have stalled given what's happening nationally right now. Disparities, race, equity, and inclusion. So when I talk about disparities and race, equity, and inclusion, I'm talking about the general theoretical concept that bias or implicit, actual bias or implicit bias you don't even know about, is causing either an access or an outcome disparity because of people's demographics, including race or other demographics. So we have pockets of folks who we'll consider vulnerable populations either because of race or ethnicity or because of gender issues or sexual orientation, and you can see, when you see the data, their health outcomes are not as good. Why is that? We don't know. So the state of Connecticut has decided it is going to look into this better, and once again, if they just had all the data, they could figure it out. So racism has been declared as a matter of law in Connecticut a public health crisis, so that's important to know. And remember that thing I read to you about the unemployment quarterly filings? So they're going to start collecting a ton of information about patients as well. They haven't got their act together yet, but it's the writings on the wall on how this is going to work. It will affect you actually, not just I have to report it. Eventually someone will tell you what to send and to whom you have to send it. Got it. It's going to force more conversations that we started having and then it sort of became routinely ignored on capturing demographic data on a patient, whether that's in your portal before they come in, whether that's an existing patient and you ask them a questionnaire, whether that's when they come in, you have someone sit with them. But we need more granular information on their ethnicity. So right now you've got, best I can tell, we got white Caucasian, black, Latino, well, white Caucasian, black, other Asian / Pacific Islander, and then we have ethnicity, right, Hispanic or not. You're going to go from those essentially 5 choices, I'm laughing because it's not going to work, to about 500 choices. So the form's only going to have like 11, and then it's going to have an other, and somehow you'll know the other 489 choices. So this is going to be a big change. If you have an EMR, it's going to get baked into your EMR at some point because you won't be able to be a healthcare provider in Connecticut if you can't do this. It won't happen right away. It's already the law, but again, the agencies haven't got together exactly what they want you to do. Also going to collect more information about people's gender and sexual orientation issues to be reported to the state, which most people don't enjoy. And a bunch of things that the concept makes sense. States should be making a better role in building a platform to get at why these health access issues and outcomes are different for people in different categories. Got it. They're going to start by collecting a lot of data. They're going to make you collect and send them. So we're going to probably be next year with a whole list of what that is, because it'll take them about that long to get the list together, but that's a real thing, different from how you do it now. And I can tell you, I think the worst part isn't the doing it. We'll all get used to it. The worst part will be your clinicians are going to go, I am not going to read a list of 300 Asian Pacific type people to this lady, except you might have to. So there will be a training component to this when they get their act together. So they've also created a bunch of new commissions to study the problem with the data they don't have yet. So there's an entire commission that's going to figure out why we have racial disparities in public health and then make some proclamations about what to do about that. So I'd be more worried about the data thing than that second thing. Health insurance billing and collection this year. More notices between providers and insurers are required. So theoretically, the big commercial carriers can't change the plan on you or kick you off the plan without 90 days notice. We'll see. We'll see how it goes. Also, there is a clear continued shift in how billing and collection works in that what the federal and state governments are trying to do. Now, this makes sense as a consumer. It's not going to help you very much. They want the argument about why you didn't get paid to be between you and the insurer. They don't want the argument about why you didn't get paid to be between the patient and the insurer. And yet, the insurer isn't always that helpful in this, and you don't necessarily have all the information, and a lot of it comes down to plans, right? Maybe the patient has a large deductible. Maybe the patient has a different health benefit situation or plan. Maybe they're self-pay. And yet, they want to make it so you're not going to the patient, you're always going to the insurer, assuming there is an insurer. That's not how the thing's set up, but that's where we're going. So this is essentially the modernization of what we'll call No Surprises Act, which is the federal law that doesn't let a facility charge for a person off plan when the facility's in plan. We're going to start doing that all over the place. So you're probably going to have more to do with respect to insurer relations than you do now, because you might have to jump through hoops even if the patient is responsible for the first $2,600, and then you'll have to go to the insurer first. That's how that's all going to come out, which is frustrating. Updates to the Children's Health Insurance Plan to cover more children, this is important, without regard to their immigration status. So they have found a way, for now, probably be challenged in court, to thread the needle so that folks who are not technically citizens or permanent residents can be put on a state program, as opposed to you not getting paid because if you see folks, and expands presumptive coverage for certain prenatal and postnatal care to a larger group of people. It's usually calculated by that person's federal poverty level. So there's a financial component. So it's essentially expanding who's going to be covered by various DSS programs. So moms and new babies, persons who become pregnant and new babies, and updates to not discriminating against persons who are here without citizenship or paperwork. So we'll see how that goes. They're working on how to make this function right now. Change for hospitals. So hospitals now have a new state law requirement to contact whatever friends or family the patient wants contacted. You would have thought they had to do that already. They definitely have to do that now. They have 24 hours to make a reasonable effort to contact whoever it is the patient said they had to contact. This is different than the new federal rule that the hospital has to electronically contact the GP of record when the person is admitted or goes to the emergency department. Hospitals are required to do implicit bias training for staff who have frontline duties with maternity or postpartum care. I would suggest to you that eventually we will all be doing implicit bias training, so we will see what the curriculum looks like, because this will be the first foray at that. The Department of Public Health can require access to electronic records from a hospital. You would have thought they could already do that. Wasn't technically true. So if they have a review, investigation, tumor board, communicable disease reporting, all that, they can reach into the hospital system or get a code to get it. Hospitals now. It will be you soon. So eventually anyone with an EMR, DPH will be able to get it. Remember the theme, more data. The state just has more data. They'll be able to figure more stuff out, and you have the data. So the data will eventually be more specific to what you need to collect, and more of it's going to have to go back to various state agencies when they ask for it, but you'll get notice in time. It's the scheduled break. Look at that. That's it. That's it.
Thanks, Jen. Okay, we're going to have a very brief annual meeting. We hope everyone could stay and participate and listen. So I'm going to call up our president, and he will facilitate and lead the annual meeting.
All right, that was wonderful. Thank you very much. Okay. Let's see. Notes here. And here's the page. All right. Our next event program sponsor will be coming up to the podium for a brief presentation. That's going to be Michelle Berry and Jamie Piscatello from Integris Group. Please come forward.